Θα ήθελα να συνεχίσουμε τώρα τη συζήτηση με τον κύριο Ζαούτη. Νομίζω έχετε μια παρουσίαση, σωστά. Οπότε θα ήθελα λίγο στον πρώτο γύρο αυτό να συζητήσουμε λίγο και την οπτική του κύριου Ζαούτη για να αρχίσουμε σιγά σιγά να ανοίγουμε και τη συζήτηση.
Ευχαριστώ πάρα πολύ για την πρόσκληση να βρεθώ μαζί σας. Θα εστιάσω στην εικόνα της Ελλάδος αυτή τη στιγμή στο AMR και θα δώσω την παρουσίαση στα αγγλικά. Τη συζήτηση με μεγάλη χαρά να την κάνουμε στα αγγλικά. As Andrea mentioned, antimicrobial resistance has been now termed the silent pandemic. It's not a pandemic, it's silent because it's not a pandemic like COVID-19, which had a sudden outburst that came out of nowhere, killed many people quickly. However, this pandemic is simmering underneath, and actually was made worse by the COVID-19 pandemic. So if you look at the absolute numbers of deaths, in many places of the world, it rivals some of the death rates from COVID-19. As you've already heard, just by way of summary, antimicrobial is now one of the top global health threats of our time. Increases in deaths and disease burden in the European region. Globally, every year, 1 million people die directly from antimicrobial resistance, and nearly 5 million deaths are indirectly related to resistance. There was a number shown previously that by 2050, it is expected to be the leading cause of death globally. And that was a large UK study from several years ago. In the WHO European region, you see some of the numbers there, 133,000 deaths each year, indirectly linked to significantly more deaths. This corresponds to the disease burden of tuberculosis, influenza, and HIV combined. But yet the other ones get much more attention. It costs the European Union and the European Economic Area billions of dollars each year, including health expenditures and workforce productivity losses. And antimicrobial resistance is accelerated by the inappropriate use of antimicrobial agents. As I go on, you'll see that I'm going to approach this from the other side than Andrea. Andrea approached it from, let's make some new drugs because we need them, but what can we do to save the drugs and reduce the problem up front? So, this is data from the European Union and the European CDC. They've come up with a metric called DALYs, Disability Adjusted Life Years. How much disability and death is a result of AMR? And this is a ranking of the EU countries, and you see that Greece ranks #1 in disability adjusted life years due to AMR. If we look at attributable deaths by 100,000 population, Greece is #1 in AMR. So we here in Greece have a major problem. And I'm going to try to focus on that through the talk, and I may come across as a little strong and a little aggressive, but I think we need to really get our act together around this as a country. How do you combat antibiotic resistance? And I purposely did not include developing of new drugs on this. Prevent the spread of infection and the spread of germs. And how do we do that? Prevent of infection in hospitals, washing our hands everywhere, and also immunizations. Immunizations prevent infections that often result in an antibiotic being prescribed. Improving antibiotic prescribing and being alert of resistance patterns and understanding your data around resistance. I'm going to show you this report, or some of the summary points from this report. This is the EDC country visit to Greece to discuss antimicrobial resistance that happened during a week in April of 2024, about 6 months ago. This is publicly available. I'm not showing you anything that's private. This is a direct quote from the report. The scale of the AMR crisis in healthcare facilities witnessed by the ECDC team justifies declaring AMR a public health situation of the highest national priority in our country. And I was mentioning to Andrea that the EU and the ECDC tends to be very careful with how they frame things. Some of the words used in this report were surprising to me coming from the European Union. The findings of the visit showed that AMR and healthcare-associated infections, so healthcare-associated infections make up the biggest proportion of infections resulting from antibiotic-resistant bacteria. So healthcare-associated infection happens in hospitals, in healthcare facilities, and it's those places where we have high antibiotic use and those places where antibiotic resistance develops. Due to high levels of MDROs, multi-drug-resistant organisms, and their frequent transmission to newly admitted patients. Greece reports one of the highest rates of carbapenem resistance in Klebsiella. For those who don't know these drugs and these bugs, this is one of the last line of antibiotics we have. In the hospitals visited, there was worrying evidence of uncontrolled spread of multi-drug and, in Greece, extensively drug-resistant, XDR, which is a level beyond multi-drug resistant. Another alarming finding was the resistance to most conventional antibiotics forced clinicians to use last resort antibiotics for which already we were beginning to see resistance. And as Andrea said, that's where the need to develop antimicrobials comes in as well as part of the overall strategy. What drives the situation in our country? It's driven by various factors, including the frequent and inappropriate use of broad-spectrum antibiotics. We lead, or among the leaders in the European Union, in antibiotic consumption in the community and in hospitals. Suboptimal infection control practices, including washing our hands, isolation of patients, because our system doesn't allow us to isolate patients who have some of these superbugs, and a high prevalence of healthcare-associated infections. 12% of hospitalized patients in Greece will get a healthcare-acquired infection. That's the highest rate in the EU. So this is a vicious cycle. Healthcare-acquired infections, antibiotic resistance, antibiotic consumptions, and this goes on and on. The extremely low nurse-to-patient ratio makes adequate compliance with infection control unachievable. And the few nurses we have dedicated to infection control lack sufficient support in their daily work. Clinical microbiology laboratories lack the capacity. I mean, these are striking findings to be publicly reported. And there are structural factors in the healthcare system that promote the spread of these superbugs, such as the current practice of rotating admitting hospitals, where one night the patient goes to one hospital and the other night the other hospital is on call and patients spread these organisms. Absence of post-acute care units to reduce the volume in hospital, and a weak primary care system. So I mentioned the issue of nurses. Greece records very high numbers of doctors, but a much smaller nursing workforce. This graph shows the distribution of EU countries by whether they have a high number of doctors and a high number of nurses or low number of doctors. Greece leads the EU in the number of doctors, big number, and the ratio of low nurses. So we are the outlier there. There are several initiatives in Greece ongoing. Professor Tsipsas has one. There's another one ongoing. And often what is identified and what they told us, the ECDC, that these disjointed initiatives, everybody does their own little thing in Greece. And these disjointed initiatives fail to address the extent of the alarming public health crisis. Only an urgent, nationally coordinated effort, mobilizing all levels with strong political commitment, leadership, and coordination, could bring all the different actors together, if in Greece we can ever figure out a way to work together. The situation represents a serious threat to patient safety. At worst, it could impact the ability of hospitals in Greece to provide high-quality patient care. What do we need to do? We know what we need to do. Professor Tsipsas all of us have been sitting at these meetings for the last 20 years and saying, oh, the numbers are high, the numbers are tragic, people are dying, yet we can't seem to get anything done. We need to take the knowledge we need to combat antibiotic resistance is in the literature. We're not recreating the wheel here. We're not reinventing the wheel. We need to figure out a way to take this knowledge and implement it, make it work. We need to start evaluating what we are doing and auditing what we are doing. I know that word to us is scary. Auditing. Let's see who's prescribing a lot. Not to blame them, but to help figure out how to improve prescribing. Which hospitals have poor infection control practices? We need to get the data, and we need to audit that data, and we need to evaluate. We are worried about being evaluated. But the only way to improve is we evaluate. And if you look at the UK, you look at the US, where the UK tackled MRSA, in the United States, they've made dramatic reductions in healthcare-acquired infections. They did it by having rewards and consequences. We have to do that. There's nothing in the literature that says without rewards and consequences, we will be able to achieve better quality care. I'm going to give you an example of an initiative in the United States, and to me, it's one of the most depressing things I ever did in my life. This was a study where we did outpatient antibiotic stewardship, tried to improve outpatient prescribing in Philadelphia, where I was working prior to coming to Greece. We randomized 170 pediatricians in Philadelphia. And what did we do? We sent them a report card every month, Vathmologia, every 3 months, on their prescribing. And we compared them to each other. So Nico's prescribing, my prescribing, Andrea's prescribing. We didn't name anybody. All I knew is that my next door neighbor gave this amount of antibiotics, I gave this amount, and you gave this amount. Reduced antibiotic prescribing dramatically by 40% for pneumonia, sinusitis. It didn't alter group A strep pharyngitis because that actually has a test. So you test for strep and you can prescribe or not. 40%. What do you think happened when we stopped reporting? This is one of the saddest graphs I ever show in my talks. So what are the take-home messages from this? That unless somebody, this is sad for us as clinicians, and for healthcare, it should be for a healthcare administrator. Unless we're being watched, we don't do the right thing. Unless somebody's not counting, we don't do the right thing. We're talking about patients' lives here. So I'm going to finish with this quote from Albert Einstein. Insanity is doing the same thing over and over again, which we've been doing in Greece for the last 20 years, and expecting different results. And it's obvious that the results are getting worse. They're not getting better. Thank you very much.
Ευχαριστούμε πολύ, κύριε Ζαούτη. Πραγματικά, ειδικά με το τελευταίο γράφημα, ήταν εξαιρετικά ενδιαφέρον. Και ήταν εξαιρετικά ενδιαφέρον γιατί βάζουμε στη συζήτηση την οπτική όχι μόνο της ανακάλυψης, αν θέλετε, του discovery των καινούριων φαρμάκων, αλλά και απλά της χρηστής και ορθολογικής χρήσης αυτών. Και με αφορμή αυτό, επιτρέψτε μου, για να συνεχίσω, αν μπορώ λίγο και τη σκέψη σας, δύο έτσι πολύ απλά παραδείγματα. Αναφέρατε κάποια στιγμή τα rewards και τα consequences που έχει η συνταγογραφική συμπεριφορά. Δηλαδή, κάνω κάτι, ποια είναι η επίπτωση, παραδείγματος χάρη, ότι επέλεξα να συνταγογραφήσω πολύ. Παραδείγματος χάρη, ενώ πρόσφατα, παραδείγματος χάρη, ψηφίστηκε το ζήτημα του προσωπικού γιατρού, θα μπορούσε κάλλιστα μέσα σε αυτό το νομοσχέδιο να υπάρχει και μια ρύθμιση που να λέει ότι ανάλογα με το πόσο συνταγογραφείς, αποζημιώνεις ή δεν αποζημιώνεις. Παράδειγμα, έτσι, μπορούσε να δοθεί μια τέτοια παροχή κινήτρων για τους γιατρούς. Αυτό το πράγμα στην Ελλάδα, εξ όσων γνωρίζω, δεν υπάρχει. Δηλαδή, με κάποιο τύπου τέτοια απλά quality indicators, να υπάρχει ένα pay for performance scheme, το οποίο να σου δίνει τη δυνατότητα να σε επιδοτεί, επειδή κάνεις κάτι καλό, αντίστοιχα να σου κάνει το κάροτο και το μαστίγιο, εάν υπερσυνταγογραφείς αντιβιωτικά ενώ δεν χρειάζεται. Αυτό πρέπει να υπάρχουν πολλές μελέτες, όπως και αυτή που δείξατε και άλλες, παραδείγματος χάρη με τη χρήση του ιατρικού φακέλου. Είναι πολύ εύκολο με τη χρήση του ιατρικού φακέλου να σου στέλνουν ένα email και να σου λένε «Α, είσαι στο top 10% των prescribers», παραδείγματος χάρη, στο top 5. Και μετά να απολογίσει για ποιο λόγο είσαι, πιθανόν. Έτσι. Αυτά είναι εργαλεία, το δείξατε με ένα randomized trial με τον καλύτερο τρόπο, τα οποία είναι σχετικά εύκολα εφαρμόσιμα, αν δεν κάνω λάθος. Το άλλο το οποίο είχε πολύ ενδιαφέρον και νομίζω θα έχει νόημα να το συζητήσουμε, ίσως και ο κύριος Ήψας να επεκταθεί και η κυρία Κανή, είναι με τα quality indicators, τα οποία εξ όσων γνωρίζω στην πραγματικότητα, ενώ υπάρχουν οργανισμοί, διαδικασίες κλπ., δεν ξέρω να δημοσιεύονται με κάποιο τρόπο σε επίπεδο κλινικής. Δεν μετριούνται καν. Δεν μετριούνται καν. Φαντάζομαι οι οργανισμοί έχουν θεσμοθετηθεί στην Ελλάδα. Έτσι, υπάρχουν συγκεκριμένοι οργανισμοί που έχουν την ευθύνη αυτού του πράγματος. Άρα, αυτά τα δύο θέματα που θέσατε, το ένα των rewards και το άλλο των quality indicators, το οποίο είναι από ό,τι καταλαβαίνω τα κεντρικά εργαλεία που έχουμε για την ορθή και χρηστή διαχείριση, αν θέλετε, των αντιβιωτικών, επί της ουσίας βρισκόμαστε σε έλλειμμα. Άρα, να σκεφτούμε και σε επίπεδο εθνικό τι μπορούμε να κάνουμε για αυτά.